Hello, very good evening, friends. Today I'm sharing a late night, midnight recording of a previous webinar that I presented at Assam India webinar. That was a very short because of short time. This is a elaborative presentation recording for the youngsters, for the PGs, for the eligible enthusiasts, and for my patients also who want to get more details about this. So today I'm going to elaborate a case of knee deformity correction and how to plan it and how to correct it. Good planning and good correction, and what mistakes I did in my cases because this was the case 6 or 7 years back. Now I'm doing differently with the more planned versions. So we have to learn from our mistakes, what to do, what not to do. So it's a case of unilateral Genu Varus corrections of Ilizarov long-standing post-traumatic Genu Varus realignment. My introduction: I'm Dr. Shamsul Hoda, consultant orthopedic and Ilizarov limb reconstructions, limb lengthening, deformity correction, and infection specialist surgeon, trained from USA and Russia. Presently, I'm consultant at Rajeshwar Hospital, Patna, and Ortho World Home Clinic, and my Ortho World Multi-Specialty Hospital at Hajipur. My details are there in my website, written below. It's www.drhoda.in. So let's discuss this case of 16 years old male, Hasmatur Rahman, patient of West Bengal, India. History of left-sided post-traumatic growth disturbance. Duration is long-standing progressive bowing of the left leg. And the clinical concern is deformity compensatory greater joint length. And you can see the deformity there is in the left knee. This is the pre-operative video. You can see the knee deformity is there, walking lurch is there. While weight bearing, there's a lurch, so there's ligament laxity in these cases. And you can see there's a limb shortening also. So you have to address all those things in a go with a good planning. So with the X-rays, we have to do a very good pre-operative scanogram X-rays. So this is the primary need of the planning. The X-ray should be having a complete, including complete pelvis. So the complete pelvis to toes is very important. AP and lateral, both as lateral is missing. So you can see, still you can see here, there's a pelvic obliquity in this case. You can see here. And you can see the hip joint line is non in axis. This is down because of the pelvic obliquity. And because of the same, this joint line is non in axis. The joint line in axis, but still there is obliquity in the distal, the knee joint line. There is oblique. We have to do some correction, rotation correction from here also. And there is the proximal tibia deformity, varus deformity. So this is you can see there is a coxa vara also in this case. So we have to plan, calculate, and address everything in advance. So full length scanogram is very important. Pelvis to toes, deformity up to distal femoral valgus, proximal tibia varus, LLD femur tibia, joint subluxation is there at the knee, and there is coxa vara. You have to calculate the CORA, that is center of rotation of angulation identified in the distal femoral and proximal tibia. There is middle compartmental overload confirmed in this case. So you can see there is a fascial injury prior traumatic insult to the proximal tibia fasciis resulted in premature middle growth plate arrest while the lateral side continued to expand. There is a progression in the adolescent skeletal matured. The asymmetric growth led to a significant varus deformity, secondary ligament discrepancy. The joint mechanics chronic malalignment causes middle compartmental overloading, increasing the risk of early onset of arthritis and ligament laxity. So because of post-traumatic, there is a growth arrest. Looks like a typical Blount's presentation. But this is a post-traumatic growth disturbance in this case. So let's do the calculations. So when we apply a joint line from the center of the head of the tibia to the crossing the knee joint line in the mid and just ending at the center of the ankle, this has to be in line so that the normal mechanical axis is falls in place. But here in this case, from the center of the head of the tibia to the ankle joint, there's a severe varus malalignment. In this case, you have to calculate 8 millimeters to see the compiles. And then we calculate, we missed calculation the proximal femur. So the distal femur, we just draw a line prior to the joint line, the distal femur, do a perpendicular line of around 90 degrees, do anatomical axis, and then we see the deformities around 11 degree axis deformities there in the distal femur. So this is the MOD, the magnitude deformity is 11 degrees, LDFA is around 75 degrees. And now then we see the joint line correction angle. This JLC is distal femur and proximal tibia is around 2 degrees only. So this is normal. So then we come to the proximal tibia calculations. You can see that we just apply, draw a proximal tibia joint line, then perpendicular line to the joint line, and then at anatomical axis. Then we can finally calculate it is a 48-degree calculation. Deformity. Because the core is around 48 degrees. And then we see the final uh, mechanical axis limb length discrepancy is around 6 centimeters. So we have to address here because we should be addressing this also, but the patient came for deformity only, so we have to address distal femoral proximal tibia deformity and the LLD. So the MPTA is around 75 degrees, the MAD is around 45 millimeter, LD is 75 degrees, LLD is around, this is wrong, this is around 6 degrees. We have to, MOD in femur is 11 degrees and distal tibia proximity is around 48 degrees. So we have to finally do the CORA correction. This is the proximal tibia 11 degrees and the distal femur is around 48 degrees. So now we do the calculation in the Bone Ninja app. So we just do a cut with the distal tibia. We align. We do a angular correction and do some obligatory translation also in this case. So that it falls in line with the electromechanical axis. Then we do a cut in the distal femur so that the joint line comes in axis. Now the joint line has comes in axis, but there is some LLD. This line is down from here. We just cut the proximal tibia femur also. We just push the femur up together so that the joint line comes in axis of this line. So finally, when the joint line has come in axis, the rotation has been corrected. The final resulted plan is there. There's a more than 11-degree opening, lateral opening, which correction has to be done in the distal femur, and there's a medial opening, which corrections along with the limb lengthening in the distal with the proximal tibia, so that all the joint lines come in place. The distal, the ankle, the knee, and the hip, and this correction and the mechanical axis deviation comes in place. So very good planning is very important to attend the final deformity correction and LLD. These are very important points in this case. We'll be applying the hinges L0 or plate accordingly. This is the video planning of the same in the Bone Ninja app. I recorded the correction planning. So here we can see just drawing a line through the joints, the JLCS, and then the mechanical axis. Then we calculate the proximal tibia calculation. We make a cut in the distal tibia. We make a cut in the around the knee. We make a cut in the proximal femur. We just push the femur upward so that the hip joints comes in line. Then we just do the rotational correction in the knee joint so the knee joint comes in line and the femoral axis comes in falls in plane to the mid joint line. And then we do the final correction in the distal tibia so that the mechanical axis is corrected. Then we address the LLD so that it final mechanical axis falls in place. This is very, very important. We can also apply as hardware like Ilizarov or plates in this case to plan accordingly. So with the help of Ilizarov, we can do a very good planning because it's a multi-planar control, minimal trauma, early function and fine-tuning can be done in these cases. So frame assembly is very, very important. 3-ring construct in the femur and the tibia is very important. Accordingly, the hinges has to be placed according to the core axis. We apply KVAS and OLIVAS accordingly, so to get a plant correction and correctomy in the distal femur and the proximal tibia. So this is a final frame assembly planning of the same. The proximal ring, you can see the proximal femur part. The distal femoral ring is in line with the joint axis. Similarly, the proximal tibia is in line with the joint axis. And the rest of the proximal femoral rings are in the perpendicular to the shaft, and the rest of the distal tibia rings are in the perpendicular to the shaft. So we'll be doing corrections over here. Placement of hinges and distractors are very, very important. So since we are doing a opening wedge from here, so we have to apply the hinges just along the shaft on the convex side, and these are the distractors for the opening wedge and the distal femur. Similarly, the proximal tibia, we have to do correction as well as some lengthening. So distractors are little away from the plane of the lateral side of the tibia, and just one anterior, one posterior, similarly one anterior, one posterior, and there's a distractor in this case. So they have to do opening wedge in this case from here. This is the shank spin to stabilize the assembly. and the destruction of the motors of the destructor rods, and hinges are placed at the deformity apex. So this is the first thing applied here. In this case, you can see two levers are applied to control lever to control the gradual correction so that the tibia doesn't pushes away. So this works as a thumb for the correction. These are two wires, and then we apply a shank pin here. Then we do a cortotomy in this proximal part. You can see a cortotomy in this level, and then apply the hinges in this case. So the short video for the same. You can see there's a stand made with the Ilizarov rings to right side to right side. This is for the lengthen the rings so that you can clearly see the AP lateral view without any difficulty. So this is the stand made with the Ilizarov rings. Post first ring proximal ring placement. This is in line with the joint line. We have done a cortotomy at this level for a opening base from here. Cortotomy, and there is a hinges placement of here. These are the distractors. These are the hinges. This is the final assembly with of the femoral part. So now the femur part, you can see the distal tibia, distal femur cortotomy is there. The rest of the part is fixed with the shank pins. So good stability, stable femur is very, very important in this case. We can connect this with the hinges for while movement. This is the assembly from different angles. The final assembly. This is the final assembly. Let's see what the Varum says. So let's see what the patient says. This is for the my patients. Let's see what the patient's feedback is there. How we have to train the patient. Patient training is very, very important in all the cases. Not 5 months, 3 months. So patient training is very, very important in all the cases. Patient learning is very important because in the frame assembly, we applied shank pins and the you can see olivers are there and contour relief for the stability of the rings. So the patient learning and feedback and testimony is very important. Learning always for our surgeons. Feedback is very important in all the cases. So let's get back to the academics. You can see there's a gradual correction is there. There is a little displacement in the distal femoral part that was lightly corrected in the OT. Uh, Hinges were placed accordingly. So gradual correction was done. You can see a little opening base has been done. Little has been done in the femur also. But there is still varus and shorting is there. So one more X-ray is missing that shows more alignment corrections. And these are the final alignment corrections clinically. So one more worry. This is the this clinical picture is according to this X-ray. There is a little virus, and the last X-ray is missing because you can see there is finally complete virus correction is going to valgus also, and a little lengthening also is there. So a little shortening of the tibia is there. So we advise the patient to get more lengthening now, but the patient was adamant. Now my leg is more than enough. This very notorious child. He was not ready to get more lengthening. So we had to stop here after this correction. So although it was not ideologically correct, so we have to stop here, and the patient was adamant to ring to be removed and some plate to be applied. So sometimes you have to hear the patients, we have to stop, why not to. But in any case, you have to do the final corrections. Final correction, the X-rays are very, very important for a good pain-free movement. So this is the final corrections. Post-op, you can see the virus has gone into valgus. And you can see this case, the LLD is completely normal. The left limb looks more than lending to this. You can see the gait of the patient. From posterior shot, little virus was there. You can see the whole alignment of the patient. So it is not congenital disease, childhood deformity. The alignment has been. So patient feedback is very important in all the cases. Let's see what other deformity patients say about Ilizarov surgery. So different patient comparison is very, very important beside academics for better learning. We have to promote the physiotherapy also for the range of motion. Very, very important in all the cases. So final picture, the patient was adamant to remove the ring while still in a little virus, you can see. Uh, the mechanical access has been completely corrected. The wood, very good regenerate is there. Blade was applied. And there is a little shortening in the tibia, you can see. This was supposed to be addressed. This is mandatory on the cases. This is a learning for me. For me. We have to do a complete besides opening wedge, we have to do a lengthening of the tibia also in this case so that the pelvic obliquity goes up and the jointing comes in place. But the patient was more than satisfied, so that he said that my left leg is more than lengthened. This was because of the pelvic obliquity. As we lengthen the tibia from this side, it pushes it up and the pelvic obliquity comes in place. So don't listen to the patient in any case. Do the complete lengthening, do the complete correction, distal femur, proximal tibia, lengthening, and the coxaver also. So mechanical access has been corrected very well, regenerated as well. Patient is very more than happy. So besides there was little virus, and this is a mechanical access correction. So pre-op, you can see the mechanical access division. Post-op, the mechanical access it's almost corrected. You can see just a little part is there, but it's a very good alignment is there. So X-ray clinical part is very, very important in all the cases. This is the learning, do complete correction. So this is the pre-op and post-op corrections in these cases. So pre-op and post-op photographs are the same for anything. This is the video of the same. You can see complete correction. So getting a clinical results is very important in all the cases. Clinical results अच्छा होना important है. Radiologically भी correct होना very, very important. So the timeline is week 0 to 1 with the surgery and latency period was done. Focus on wound care, distraction phase, gradual virus correction 2 to 6 weeks. Month 3 there was consolidation phase, bone, muscle and hardening. And month 4 the frame removal, plate application, progressive weight bearing was done. A very good physiotherapy is very important. We have to take care of the pin-type infection, daily cleaning with antiseptic and aggressive oral antibiotic therapy for early signs of inflammation. We have to check for the joint stiffness, intensive daily physiotherapy for range of motions throughout the film duration. And after that, if still there is stiffness, we can do a later Judas cortisoplasty later stage after 1 to 2 years at the time of plate removal. And then we have to take care of the neuropraxia. If there is some neuropraxia, we need to do a CPN release also in a few cases. Because the surgical output alignment is very important. We have to check all the deformities, limb length equality is very important. Function has to be normalized. Radiologically, you have to get complete correction in all the cases. So this is the final picture, pre or post-op, typical deformity case. So the take-home message, the summary is that we have to do precise planning. Acute CORA analysis is non-negotiable. Placing hinges at apex of deformity ensure pure angular correction without induced translation. Biological aspect is very important. Low energy control preserves the medullary and peripheral blood supply, which is critical for healthy destruction osteogenesis. Functional priority we have to encourage early weight bearing and knee mobilization. Functional loading accelerates mineralization and present joint stiffness. Mechanical balance aim to for overcorrection to the Fujisava point, lateral to center to effectively offload to the denoted middle compartment. These are the points you have to take in all the cases. So the question arises, we have to check for the knee stiffness, there's for the residual virus, LD has to be addressed. We have to do some overcorrections. So with the message of destruction osteogenesis offers a powerful biological tool for the management of complex multiple deformities. Presented by the limb reconstruction unit of the hospital Ortho World. You can just scan this QR code to get details of my clinics, my WhatsApp, my email, my everything. By this, you can get in touch with me, with my manager. We will be answering to all your questions. This is for the young surgeons, for the PGs, for the postgraduates, all the patients who want to get an inquiry for the deformity correction, limb lengthening, infection, or any Ilizarov cases around the world. You can please scan the QR code and contact us. Thank you. Thanks a lot. And good night, because since 1 a.m. we have to do some more studies for the next case. Thank you.